Other areas like this are somewhat dangerous, and we're going to show you ways to make them less dangerous, where the arteries get superficial. So you've got to know the areas where superficial injections pose some danger and when they're safer. Another area that superficial injections are somewhat dangerous is in the nose. And because there are a lot of anastomoses in the nose, this provides a real danger. The other reason it's a danger is there are connections with the internal carotid system. This is supratrochlear, supraorbital, some of the nasal vessels, and the external carotid system. As a general rule, most of the arteries and vessels within the nose run in the continuation of the nasal smaz. So the smaz is along this layer and continues up over the nose. The vessels run within that layer. So a superficial injection, whether it be with cannula or needle, can get some of these vessels, like the dorsal nasal vessel, the artery and vein, and the communicators across the nose of those dorsal arteries. So if we want to do a nasal injection, we would like to be deep just pre-perichondrial or pre-periosteal. We'd like to be down on the bone or the cartilage and below the vessels. When we look at the layers of fat in the midface, we have a superficial layer. I'm pointing to that. And that envelops the entire face. This is superficial fat of the face. It's called the malar fat here, and the malar fat extends all the way to the nasofacial line, the groove between the nose and the face. So the malar fat pad almost goes up onto the nose. We can peel away that and expose the deep fat of the face. So if we peel away the fat by taking it off, and if you notice, the orbicularis oculi muscle comes down and interdigitates, going slightly underneath that fat layer, we can peel away the superficial fat, layer 3. And that exposes the muscles of the midface and the deep fat of the midface. It exposes both of those. And we can peel this fat away. The fat overlies all the deep facial musculature. It overlies the deep fat of the face. So let's talk specifically about what those layers are and where we inject when we typically inject to augment the midface. So as we look and move this superficial fat layer away, which is the fat layer that has the smaz housed within it, we can see the zygomatic major muscle. This attaches to the modiolus, which is the thickening of orbicularis at the corner of the mouth. Also attached to that is the DAO. It pulls the mouth down. The LAO, which pulls the mouth up. And as I mentioned, the zygomatic major muscle. Contraction of the zygomatic major muscle creates a groove, and the groove is always perpendicular to the axis of the muscle. So the muscle is here, and the melolabial groove is just along the axis of that forceps. It's perpendicular to the axis of the muscle. The deep fat of the midface is the lateral souph, the medial souph, and the deep central fat compartment of the midface. That's housed between the zygomatic ligament, the attachment of the zygomatic major muscle to the bone, and the facial vein, which is not seen, but runs deeply underneath the musculature here. So if we make a triangle between the zygomatic ligament and the facial vein, the medial souph, the lateral souph, and the deep central fat compartment of the midface are housed within that. Now, if we augment the midface, we're typically augmenting the lateral souph, sometimes the medial souph, and sometimes more inferiorly, the central fat compartment of the midface. If we want to create more of a tail on the zygomatic arch, we will inject right onto the top of the zygomatic arch. As mentioned earlier, there are a couple of ways to do that. You can either do it with a tangential injection that can be done with a needle or with a cannula. And typically the orientation of that would be in this orientation. Or you can do that by depoting and using a perpendicular injection directly down onto the bone. And we can do that back along the zygomatic arch and fill up more of the tail of the zygomatic arch to give the face a nice lateral sweep and lateral augmentation. So augmentation of the lateral midface involves injection into the lateral suit, the medial suit, and the central fat compartment, which are housed between the zygomatic ligament and the facial vein. These are all deep fat injections in the face. Another important injection for injectors is to inject the tear trough concavity. That's a little bit of an odd term, and it really isn't a trough for the tears. The etiology of this tear trough concavity has to do with where the ligament that attaches the orbicularis oculi muscle attaches to the bone. If you look at the orbicularis oculi muscle here, as it sweeps around the eye, it's a concentric muscle. I think of the orbicularis oculi like bacon. It has some muscle, then some fat, and then some more muscle in it. At the medial border, or the inferior-medial border of that, is the facial vein. The muscle actually goes into the eyelid itself and then comes down onto the orbital bone, the malar bone and the zygoma in this area. If we look at the concavity that's created by the deep attachment of the ligament, the so-called tear trough ligament, which is the medial continuation of the orbicularis retaining ligament. The orbicularis retaining ligament connects the orbicularis oculi muscle down to bone. The medial portion of that is called the tear trough ligament. In that area is where we have a concavity. The concavity is bridged by the fat of the midface centrally and the eye fat, the deep fat of the eye, which pooches out when we push on the eyeball. So in between there is a concavity, and when that concavity looks deep, we have what physicians call a tear trough. And augmentation of that tear trough with hyaluronic acid filler or with fat creates effacement of the tear trough and makes the eye look smoother in this area, the eyelid look smoother in this area. So we want an injection in this area. What is important is to know where the structures are that can hurt us. Certainly, more medially, we have angular vessels, and we have vessels that come from the infratrochlear in this area. We also have, below and deep to us, the infraorbital, and I've put my long cannula right into the infraorbital foramen. That foramen is just medial to the midpupillary line. So if the midpupillary line is here, the foramen is just medial to it, and its average is about 7 millimeters below the inferior orbital rim, the rim actually. And it's obliquely oriented. Notice that the foramen does not come straight out of the face. I've angled my cannula this way. What does that mean for us as an injector? If we're approaching something from lateral, it's hard to get into the foramen. But if we're making a medial injection like this, it's very easy to be into the foramen or into a vessel that comes out of the foramen. So we have to watch out for that. So I like filling with either a needle or a cannula above the infraorbital foramen and the canal in this area. And I typically inject down onto bone in this area. Notice I'm lateral to the angular, above or superior to the infraorbital vessels, and below the orbital rim. That's a fairly small space. We've got to put it right in that space on bare bone, and that allows us to fill up the concavity and efface the tear trough. I'm next going to talk about augmentation of the chin and the jawline. What is important when we look at this is to look at the texture and the makeup of the fat. Again, the superficial fat layer is pinched by me here. You can see there's no fat on the lower eyelid as we go down the face in this single layer of superficial fat. The fat goes from less dense to more dense, and over the chin, it is very dense. In fact, the fat overlying the mentalis muscle at the chin is interdigitated with muscle itself. In the area of the depressor anguli oris, the fat is smoother, it's not as tightly bound, and it easily elevates off of the DAO, and in fact the DLI. But as we lift the superficial fat away, we can see we can easily lift it away from the deep tissues, but it's not so easy to lift it away from the area over the mentalis muscle. And in the mentalis muscle, this muscle is interdigitated with fat, which goes all the way up to the pagonian, or the most anterior projecting point of the chin. Now, when we augment the chin, we have to decide what we want to try and achieve with the augmentation. I look at it in several ways. We may want to just project the chin, give it more in an AP direction. We may want to make it a little wider, increase width transversely. We may want to make it longer or shorter. It's tough to make a chin shorter, but what I do when I inject a chin that's very long is I inject on the upper part of the dome, and that gives the illusion as we're augmenting the chin that it's shorter. So we can affect the vertical length, shorter or longer. We can affect the width by making it wider, and we can affect the projection by making it more projected. That gives us the ability to shape the chin. So how does that come about? We take a needle or a cannula, and in this case I've got a cannula, and we pass it from lateral to medial, and we go under the pagonian. This is if we want to do it tangentially. A second way to do it is to pass the needle perpendicularly from the skin and put it right through the skin and deposit this deep to the muscle. In either case, the injection that we're doing is underneath the muscle on top of the bone. It is immediately pre-periosteal. So we can augment the pagonian, that gives projection. We can augment lateral to the pagonian, that gives lateral augmentation and increases the width. And lastly, we can augment inferiorly to improve length, or superiorly to make it look shorter. One thing that's very important is all of these injections that I've talked about are deep injections on the bone. In the event that a patient has a very deep labiomental sulcus, the sulcus is deep, and we want to slightly efface that sulcus, not have quite so much a groove there, that becomes a superficial injection. So we can't be deep here, because if we were deep, we would be injecting filler right inside the mouth, because the sulcus comes down a certain ways, and if we're going to inject onto the bone right here, it's going to be in the mouth. So most of the inferior injections are down on bone. The only one that's not on bone is if we want to inject the labiomental sulcus, and we'll inject that relatively superficially. And these are the ways to augment the chin and the jawline. Botulinum toxin around the chin and into the lateral chin and corner of the mouth can be performed. Let's first talk about botulinum toxin in the anterior chin. This is done for a couple of reasons. One is if the patient has mentalis strain and has a dimpled chin. And this often comes in patients that have a small chin and the muscle is actually trying to hypercontract to close the lips. When I do that, I inject either in the center or just paramidline, and I'll inject, if I'm doing paramidline, 2 little points,